So here I have presented an outline of what the PowerPoint presentation will consist of. Post-traumatic stress disorder is a complex and dynamic mental health disorder due to the subjective experience of trauma. PTSD is often a comorbid mental illness presenting with co-occurring diagnoses such as anxiety, depression, and substance use disorders. These factors and the complicated symptoms with which individuals present contribute to the complexity of treating PTSD. Cognitive processing therapy has solid empirical data to support the effectiveness of treating PTSD, and it has emerged as one of the highest recommended PTSD treatments. CPT is a form of cognitive behavioral therapy that focuses on the modification and examination of maladaptive cognitive processes. So the goals of therapy are to improve understanding of PTSD, reduce distress about memories, decrease emotional numbing and avoidance, reduce physiological symptoms, decrease the comorbid disorders, and just to improve day-to-day living in general. The standard course of CPT is established as a 12-session treatment. However, it is important to not assume that clients will need 12 sessions to ameliorate their PTSD and comorbid symptoms. Clinicians should inform clients that the protocol was originally developed to be 12 sessions long, but that some people may recover quickly, while others may need more than 12 sessions. Depending on client progress, CPT may last between 6 and 16 sessions. CPT was originally developed for people with PTSD who may be experiencing additional disorders and conditions. In both research and clinical practice, CPT has been effectively utilized with individuals in timeframes ranging from 3 months to as much as 60 years after their trauma. CPT can be an effective choice for a wide range of individuals and can help them live more symptom-free lives. In order to complete this goal, the therapist will offer psychoeducation regarding trauma and PTSD, and the client will be asked to complete assignments outside of the session. CPT is a structured treatment for post-traumatic stress disorder based in foundational elements of CBT, cognitive behavioral therapy. In treatment, we focus on constructing meaning of the traumatic experience to understand why it occurred, understanding how trauma impacts one's beliefs about oneself, others, and the world at large, identifying how best to readjust one's beliefs to recognize more balanced and effective ways of thinking in the aftermath of trauma. Topics covered in CPT include the meaning of the traumatic event, the identification of thoughts and feelings, and then there are specific sessions designated to cover a theme and to help recognize negative beliefs, and these are known as stuck points. The first theme is trust. When individuals experience trauma, they may feel unable to trust their own judgment or others. In order to prevent further harm, individuals may adopt strong beliefs such as, I cannot trust anyone, or I'm not able to make sound decisions. Safety is the next theme. After a traumatic experience, individuals may consistently feel unsafe in the world, and perhaps even unsafe in their own skin. They may experience difficulty staying in touch with their own body and minds. Individuals may also feel a tendency to withdraw from people and surroundings that remind them of the traumatic event. Issues of power and control. Frequently, trauma survivors feel powerless to prevent the experience they endured. As a result, it's common to extend this belief to think, I am powerless over all aspects of life. By contrast, some may develop the opposite belief that I must be in control of my life in order to prevent another traumatic event from happening again. Esteem issues. When a traumatic experience has resulted in a consistent feeling of not being safe, a distrust for themselves and others, and an extreme fear of being controlled by others, it is common to develop extremely low self-esteem or a low regard for other people. And finally, intimacy. When their life has been seriously threatened or harmed, especially by another human being, they are often left feeling extremely uneasy in connecting to others. Thus, they may want to withdraw from others entirely, or at least severely restrict their circle of relationships. And sometimes the latter response can result in an unsustainable dependence on others. Benefits of CPT. Clients who've undergone CPT often report the following benefits: insight as to how awful events can happen to good people, decreased time and energy spent trying to exert unrealistic control over one's life in efforts to prevent tragedies from reoccurring, more flexible beliefs rather than rigid or extreme beliefs, which in turn leads to flexible behaviors. For example, being able to trust some people while recognizing how others may not be as trustworthy in certain domains, such as with secrets, money, fidelity, that kind of thing. Acknowledgement of underlying sadness for what has been lost in their lives as a result of trauma. Open expression and processing of appropriate anger towards their perpetrators of harm. Increased ability to forgive those who were incapable of stopping the trauma from occurring. And increased ability to forgive themselves for not being able to prevent or change the outcome of the tragedy. Origins of CPT. Understanding the foundational theoretical underpinnings of the modality serves to assist the therapist in clinical decisions throughout the therapy process and the ability to explain the rationale behind components of the therapy. The development of CPT can be traced through several theories and schools of thought. CPT was first established with theories of first and second order classical conditioning responses, developing and creating avoidance symptoms in response to reminders and neutral stimuli from the trauma. Early learning theory sought to explain the development of PTSD through classical conditioning, essentially supporting the idea that learned associations can cause a continued fear response, even after the removal of the frightening stimuli. Classical conditioning does not fully explain PTSD, however. According to classical conditioning, this learned fear response should extinguish over time. For example, a child sexual abuse victim began to associate the color yellow with danger because that was the color of the shirt of her perpetrator. The theory posits that if she continues to see the color yellow and no perpetrator appears, over time, the child sexual abuse victim would eventually learn yellow does not mean danger. But we know in the case of PTSD, the fear response is often as strong as the response during the traumatic event. After working with large numbers of women who were suffering from PTSD from a rape, Dr. Resick, the founder of CPT, found that PTSD was not simply a fear or anxiety disorder. Dr. Resick quickly progressed to the theoretical foundations of emotional processing. Schemas are created due to traumatic events. Illogical schemas and threats are maintained due to avoidance. PTSD is believed to emerge due to the development of a fear network in memory that elicits escape and avoidance behavior. Mental fear structures include stimuli, responses, and meaning elements. Therefore, anything associated with the trauma may elicit the fear structure or schema and subsequent avoidance behavior. Prolonged exposure therapy for PTSD is based on emotional processing theory and posits the only way to teach individuals the threat is no longer there is to expose them to the avoided or dangerous stimuli. And over time, the fear will extinguish. I will use the same example from earlier to explain this concept. The victim associates the color yellow with danger, and so she avoids the color yellow. Therefore, she is exposed to yellow over and over until she comes to the realization that seeing the color yellow does not necessarily mean danger. Next, Dr. Russick began to research Beck's cognitive approach because studies revealed additional complex issues within individuals suffering from PTSD, such as shame and guilt experienced by victims. Social cognitive theory posits the way in which an individual cognitively processes a traumatic event impacts his or her emotions. Moreover, additional research found that cognitive distortions were positively correlated with more significant PTSD symptoms. Here in the example, if the abuse victim believes the trauma occurred because she deserved it, she could develop PTSD. However, if she changes the cognition to something really bad happened, but it's not my fault, this completely changes her emotions regarding the event. Eventually, CPT emerged as a social cognitive modality with a theoretical foundation based on helping the client identify and change trauma-related cognitive distortions. According to this theory, recovery from PTSD relies on the activation and subsequent correction of faulty cognitions and their related emotions. Full cognitive processing of the trauma could alleviate negative emotions associated with the trauma and reduce symptomology. The literature continues to expand in evidence that suggests a reduction of negative beliefs associated with trauma will reduce PTSD symptoms. Biological concepts. When a person experiences a life-threatening emergency, the fight, flight, freeze response is activated. Specifically, the amygdala triggers a release of neurotransmitters that decrease the activation of the prefrontal cortex. Once the prefrontal cortex recognizes the threat has passed, it sends a message to the amygdala that it is safe for the body to settle down. The prefrontal cortex is where executive functions are controlled, including higher order thinking abilities, such as decision-making, planning, and judgment. Why? Because in an emergency, it's more important for the body to protect itself, to keep the heart pumping, increase breathing, etc., than to plan or think about other things. Research has demonstrated that PTSD decreases the post-emergency prefrontal cortex activity. The prefrontal cortex is not able to recognize when the perceived danger is no longer a threat, so the amygdala does not receive the message to calm down. Because certain things, such as sights and sounds, can become conditioned stimuli for people suffering from PTSD, many things become triggers to activate the fight, flight, freeze response, with less possibility of quieting the amygdala. So how can CPT disrupt this trauma-conditioned biological feedback loop? Imaging studies have demonstrated that talking about what is causing one's distress activates the prefrontal cortex. After all, organizing words and thoughts is a prefrontal cortex activity. Thus, cognitive therapy, where the patient is asked to talk about the trauma, answers questions, and thinks critically about what they are telling themselves, can help a patient with PTSD bring their prefrontal cortex back online. The goal with CPT is to help strengthen skills associated with the prefrontal cortex function, such as thinking critically and with greater flexibility about trauma experiences. The more the client reflects on how they think about themselves and others, the more likely the prefrontal cortex can successfully communicate a calming message to the amygdala. Best practice guidelines dictated by national organizations endorse therapies based upon empirical support. CPT has a long history of published clinical trials resulting in effectiveness related to positive outcomes for the treatment of PTSD. Because of this growing evidence indicating promising results, organizations such as the American Psychological Association and the United States Department of Veterans Affairs endorse CPT as a gold standard PTSD treatment option. Furthermore, meta-analytic results have shown that CPT is an effective treatment for PTSD, resulting in lasting outcomes across multiple life domains among a variety of populations, cultures, and languages. There's also strong empirical data supporting the efficacy and effectiveness of CPT in its various forms and with various populations. In fact, 2 recent meta-analyses of PTSD treatments comparing various evidence-based cognitive behavioral therapies and medications found that CPT had the highest average effect sizes of all interventions examined. The role of the clinician. The role of the clinician includes Socratic questioning, teaching skills, identifying and discussing avoidance, and accountability for expectations. Socratic dialogue is a cornerstone practice in CPT. This practice involves the clinician asking a series of questions designed to bring the client toward a healthier and more balanced appraisal of both traumatic events and the effects of those events on the client's reactions to situations in the present moment. Teaching skills include ABC worksheets and teaching about natural emotions and manufactured emotions. ABC worksheets discuss ways to break unhelpful thinking habits with more adaptive thinking styles. Successful implementation of CPT depends on the ability of the clinician to use and teach strategies that allow natural emotions to be experienced fully, at which point they usually dissipate on their own. On the other hand, one's thoughts related to manufactured emotions must be challenged, as erroneous thinking contributes to non-recovery. I'm going to discuss both these concepts later in the presentation. Another important responsibility in the CPT protocol is to notice and point out when your client is avoiding working on the trauma. Avoidance is a key PTSD symptom that keeps people stuck in non-recovery. Clients may not know when they are engaged in avoidant behavior. Avoidance is a powerful component of PTSD and can significantly interfere with a person's willingness to engage in therapy. It is important to address avoidance prior to starting treatment and will most likely be an ongoing subject to focus throughout therapy. Remember, people employing strong avoidance tactics are often well practiced at shutting down their emotions. As a result, they do not process their emotions and they struggle to examine their beliefs as an event, themselves, or the world, often because of a fear of feeling intense emotions. By addressing your client's avoidance behavior directly, you're helping them take powerful steps towards recovery. And finally, accountability. You should make it clear to your clients from the beginning. The most important expectation of CPT is that they come to every session. Additionally, you should make sure your clients understand that there will be practice assignments to be completed outside of the sessions. These assignments are designed to improve PTSD symptoms more rapidly than would be possible with only in-session work. A certain amount of commitment is necessary to complete the treatment, and it's not an easy process. Some people find it difficult to get through the sessions or to do the homework. It is unlikely that CPT will be helpful without completing all the sessions and doing the homework exercises, though. So why is the homework so important? The exercises ask the client to practice examining thoughts and emotions in specific ways that reduce the symptoms of PTSD. In CPT, if you don't practice these new ways of thinking, you won't see the change you want. Don't be fooled by the word homework, though. CPT definitely feels much more like therapy than doing schoolwork. Treatment considerations. So, who is CPT for? Most of the studies that support the efficacy of CPT have been conducted on adults ages 18 and up. However, there have been a small number of studies suggesting that CPT can be effectively delivered to adolescents in the 14 to 17 age range. There is no evidence indicating that the efficacy of CPT varies across racial or ethnic groups. Similarly, CPT works with patients who live in urban, suburban, or rural areas. With respect to gender, it is clear that CPT works well with both female and male adults. There are some studies indicating that CPT may work even better among women, but this finding is not consistent across studies. The best evidence is that CPT is an effective treatment for all appropriate clients, regardless of their demographics. CPT has been effectively used with single and multiple incident traumas. Although CPT was developed originally for adult rape victims, the treatment has been applied to a wide variety of traumas, including combat, physical assaults, gun violence, and natural disaster. And the treatment works even for adults who have been exposed to multiple different styles of trauma across a lifespan, such as what we see in complex PTSD. CPT can be delivered anytime from 1 month to 60 years after the experienced traumas. CPT is designed for people who have multiple symptoms of PTSD, but a patient need not meet full diagnostic criteria for the disorder in order to benefit from the treatment. Furthermore, numerous studies have found that in addition to improving PTSD, CPT also resulted in significant reductions in depressive symptoms, improvements in sleep, and reduced relationship difficulties. So, who is CPT not for? If a person does not have a known and remembered history of traumatic events, CPT is not suggested. Some people are quite resilient and possess effective coping skills to help them manage potentially traumatic experiences effectively. Consequently, they may not have durable mental health symptoms related to those experiences. If someone doesn't have clinically significant problems related to traumatic events, CPT is not suggested. Finally, if the individual has severe cognitive challenges or other problems relating to their level of functioning, CPT is not suggested. There is a version of CPT that can be used with clients who have intellectual, cognitive, or other problems that can allow them to engage and benefit from a cognitive therapy. In cases of severe intellectual disability, CPT is not indicated. Some individuals may be exhibiting certain symptoms or behaviors that make it very difficult for them to engage in trauma treatment. Generally, these problems should be managed first using appropriate, evidence-based treatments. When the complicating problems are brought to an acceptable level, CPT can begin. Common examples of these problems are unmedicated mania or psychosis. It's just impossible to effectively conduct trauma treatment when reality testing is significantly impaired. Severe depression, such as if the patient can't leave the house or take care of basic needs. Severe substance dependence requiring detox, and active suicidal ideations. Imperative CPT concepts. These include stuck points, Socratic dialogue, and natural versus manufactured emotions. Stuck points interfere with acceptance of the event, which is assimilation, extreme overgeneralized beliefs over accommodation, or thinking that if you had done something different, everything would be fine, which is hindsight bias. Stuck points can include over-accommodated beliefs, which is a change in prior beliefs in an exaggerated fashion to the opposite extreme. An example is, I can never trust any man again because all men are potential rapists and might attack me. This is over-accommodation. Assimilation is the altering of the interpretation of selves or the event to fit prior beliefs. I must have done something wrong because bad things don't happen to good people. This is assimilation. Another example of assimilation is the use of new traumatic events as proof of pre-existing negative beliefs. See, bad things always happen to me. Hindsight bias is thinking that if you had done something different, everything would have been fine. And finally, accommodated beliefs are where we want to get to. This occurs when individuals modify their prior beliefs to incorporate the traumatic event to a more balanced worldview. Some people and places are dangerous, but the risk of danger in most situations is tolerable. Here are some examples of stuck points. Assimilation, I must be a bad person because this happened to me. Over-accommodation, I must control everything around me. And then accommodated thought is in the middle, which is I do have control over my responses and actions. Socratic dialogue. The foundation of the Socratic method values the power of the individual coming to know something new for themselves, as opposed to being handed insight or knowledge from another person. It also models the benefits of curiosity and inquisitiveness. Socratic dialogue helps the client find their own wisdom with the goal to eventually learn to become their own therapist. This strategy fosters less dependence on the clinician and encourages clients to take more responsibility for their treatment. Clinicians are there to help facilitate rather than merely give advice, insight, or formulations in this model. The key to Socratic dialogue in the CPT process is guided discovery. Socratic dialogue can help the client see how this feeling would remain true or untrue based on learning more about the circumstances beneath the immediate event. It can help determine whether the client has made a simple blind assumption or has developed more complex thought patterns. The Socratic dialogue hierarchy. Clarifying questions are at the most foundational level. Clinicians should ask as many clarifying questions as possible to set the stage of what was going on at the time of the traumatic event. Setting the stage helps identify what choices and abilities the client had at the time of the event, rather than focusing on what the client might think about it later. It is extremely important for clinicians doing CPT to be willing to ask sensitive and difficult clarifying questions as non-judgmentally and matter-of-factly as possible. Some examples of clarifying questions include, when did you know that he could be so violent? Or what were your options at the time? The next level of Socratic dialogue challenges the assumptions that underlie the client's conclusions about traumatic events. The just world belief, the idea that good things happen to good people and that bad things happen to bad people, and that the world should be a fair place and just place, is a key assumption often held by individuals with PTSD. There's a common desire to find cause-effect associations between one's behavior and what happens, because that provides a sense of control and predictability. Challenging assumptions about causality is one example of how to loosen the strength of a client's stuck points associated with the trauma. Whether it's the just world belief or another belief, Socratic dialogue can expose the thinking that keeps the client stuck in their recovery process. Some examples of challenging assumptions include, what else could have happened if you fought back? Or, when they left, did your friends have reason to think that he would attack you? The next one is evaluating objective evidence. This next level of Socratic dialogue helps clients objectively evaluate evidence that may or may not support the conclusions that they have drawn about the traumatic event. Individuals with PTSD often have a cognitive bias toward perceived threat in particular and negative information more generally. Examples of evaluating objective evidence include, what is the evidence that you are responsible for in this death? And how often do break-ins occur in your neighborhood? And finally, challenging core beliefs. There are times when clients will report they intellectually understand how they ought to be thinking, but their feelings do not align. They may indicate that their thinking does not make sense or that emotional changes are not keeping pace with their new thoughts. I know it's not my fault she died, but it feels like my fault. In its shortest form, this might be expressed as, yes, but... While changing thoughts and feelings takes time, we also encourage clinicians to consider the possibility that their clients are holding deeper underlying beliefs that may prevent them from fully embracing alternative ways of thinking. Deeper beliefs often protect individuals from the painful implications of changing their thoughts. Socratic dialogue can help identify these core beliefs, highlight their strengths, and then begin to chip away at them. Some examples of challenging underlying core beliefs include, what does it mean that you couldn't save him? Or, if it isn't your fault, what would that mean? If the client begins to argue or becomes defensive about his or her beliefs, the clinician should back off immediately and say something like this. This seems like an important topic that we will return to later. Or, I hear what you're saying. Would you be open to discussing it later? Socratic dialogue is one of CPT's most powerful tools for unlocking the stuck points around the trauma and also modeling for clients what it looks like to approach self-examination with non-judgmental curiosity. Remember to be genuine, warm, and empathetic while using Socratic dialogue. You can ask almost anything if you ask it in a curious and non-confrontational manner. Natural versus manufactured emotions. Natural emotions are hardwired, common, biologically driven emotions. These emotions are those that come automatically, such as sadness when a loved one passes away, or lust when we see someone attractive. In other words, natural emotions are emotions that follow directly after an event and would be universally experienced. These need to be felt, run their course, and acknowledged. They are like a wave. They will start, peak, but eventually dissipate on their own if allowed to be felt and processed. On the other hand, manufactured emotions are emotions that are not hardwired, biologically driven, or automatic. They are created as a result of our thinking or how we view the world. Manufactured emotions are feelings experienced not directly from an event, but instead based on the interpretation of an event. Here's an example of how natural feelings differ from manufactured emotions. The sadness that you felt when a young one passed away. That's natural. As for the guilt and self-blame you feel as a result of not taking care of them well enough or not building a stronger relationship with them before they died, now those are manufactured emotions. They are a result of your thinking and what you are telling yourself about the situation. As you can probably see, the manufactured emotions keep your anger bubbling and keeps your sadness simmering. When we work through our thoughts and allow ourselves to truly feel the natural emotions, we will cease to keep the manufactured feelings going and allow the natural emotions to be felt and processed in order to allow ourselves to heal. CPT variations. As you can see, there are several variations of CPT that can be utilized. These options are highly advantageous because they offer the therapist options based on the client's unique needs. In efforts to improve CPT outcomes and attrition rates, modifications to the therapy are continuously being hypothesized and tested. The different versions of CPT include cognitive processing therapy with a written account, or CPT plus A, group CPT, CPT for bereavement, CPT for adult survivors of childhood sexual abuse, or CPT-SA, a military version of CPT, an equine facilitated CPT option, and spiritually informed CPT. The original version of CPT does not include a written narrative trauma account. CPT plus A does. Both have been found to be just as efficacious. Therefore, it is recommended that participants be given a choice between CPT and CPT plus A. Group CPT has been shown to be an effective treatment in its own right, and for many clients, the group format helps them to address their traumatic memories through sharing their thoughts and feelings with other group members. Other advantages of CPT groups include cost effectiveness, the social support afforded by other group members, and the opportunities for clients to challenge each other's disruptive cognitions in a healthy and assertive manner. In addition, the group experience can facilitate a sense of normalization and universality regarding trauma-related symptoms by allowing clients to see that they are not nuts or crazy, and that the thoughts and behaviors are very similar to those of others who have experienced traumatic events. CPT groups should be closed and ideally should have between 6 and 9 members. Clinicians have effectively used techniques focused on cognitive processes, including meaning making and narrative therapy, derived from concepts such as continuing bonds, to help bereaved individuals cope with their losses and prolonged grief. During any potentially traumatic event, individuals' cognitions or prior beliefs of the world may be disrupted or challenged. In the context of trauma or bereavement, the cognitive processes that facilitate the formation of maladaptive cognitions may be highly problematic, as these cognitions may hinder the memories of the trauma, delay or amplify grief, and impede coping. Another adaptation is a version that can be utilized specifically for survivors of childhood sexual abuse, or CPT-SA. The CPT-SA version modifies CPT by supplementing additional sessions that focus on unique components related to childhood sexual abuse, such as the development of distorted childhood cognitions. Other relevant concepts included in CPT-SA are developmental stages, assertiveness, communication, and social support. There is also a specific CPT military manual that addresses the unique concerns faced in combat and other military-specific populations. One such way CPT is being modified is the incorporation of equine-facilitated activities into the protocol. This stems from the idea of the equine interaction serving as a bridge between the therapist and the veteran, allowing the challenging sessions to be less direct and more interactive, while working toward the same goals as the traditional setting, essentially operationalizing the principle of externalization. Equine-facilitated cognitive processing therapy, or EFCPT, incorporates the traditional CPT-12 sessions and includes the same goals for each session. It also includes focused equine-facilitated activities to be completed by the client with support from the clinician. Alternative activities are also described to increase participant choice and provide flexibility to the therapist in responding to client preference. The pilot of this adapted, manualized, equine-facilitated cognitive processing therapy model for treating post-traumatic stress disorder has demonstrated efficacy and low attrition, suggesting a viable alternative treatment option for clients who have been reluctant to engage with services. SICPT, or Spiritually Informed Cognitive Processing Therapy. Many individuals suffering from PTSD may be experiencing a spiritual crisis, or a concept known as moral injury. Moral injury is described as the deeply rooted inner conflict arising from an individual struggling to cope with a traumatic experience that is in direct conflict with their moral and/or spiritual beliefs or expectations. Similarly, individuals who have PTSD may have an intense internal conflict resulting from a rift in their core beliefs about God and the beliefs they have assimilated due to the trauma. Therefore, incorporating spirituality into the treatment is vital to decrease PTSD symptoms. Spiritually informed cognitive processing therapy was developed to address moral injury in relation to PTSD. Since faith is a significant aspect of many individuals' life struggling to deal with past traumatic experiences, SICPT would be an appropriate approach for the therapist to incorporate Christian concepts and components into trauma therapy. The added component of spirituality to this treatment option is significant since 92% of Americans believe in God and over 50% view religion as an essential aspect of life. The spiritually informed version of CPT is different from the original version in that it can incorporate Christian aspects such as scripture, Christian theology, grace, forgiveness, and blessings. Furthermore, another essential aspect of SICPT is that it encourages participants to seek support from their faith community. This slide gives examples of the concepts in SICPT in a few sessions. There are Christian concepts integrated in all 12 sessions. However, I chose a few to share. In session 2, the manual states that clients discuss their faith and Christian resources they have available, and the clients complete spiritual resources worksheet. In session 4, the spiritually integrated challenging questions worksheet is introduced to challenge stuck points using their spiritual beliefs and values. In session 6, forgiveness is discussed from the Christian faith perspective, such as, what did Jesus' death mean? And session 10, spiritual discrepancies and spiritual issues such as anger towards God are examined, and spiritual intimacy is introduced and discussed. The recognition and treatment of PTSD has come a long way over the last few decades. We believe one of the next important steps for improving PTSD treatment effectiveness is to address specific barriers of recovery. One of these barriers is moral injury, and given that moral injury is composed of both psychological and spiritual symptoms, it follows that the most effective treatments for moral injury in the context of PTSD will be those that address both types of symptoms. As such, a spiritually integrated treatment that targets moral injury may reduce one of the barriers to full recovery from PTSD and may provide much needed relief for so many people who are suffering. My personal counseling theory has been significantly impacted due to the concepts employed in CPT. The concepts and methods utilized in CPT have greatly impacted my theory by providing me new tools and techniques to use with all clients suffering from cognitive distortions. These concepts include manufactured emotions, stuck points, and the spiritually informed CPT concepts. The concept of manufactured emotions has significantly impacted my counseling approach because I believe this can be used with a variety of clients, not just solely with individuals suffering from PTSD. Emotional dysfunction can play an enormous role in a variety of mental health pathologies, including depression and anxiety. Thus, introducing and explaining the concept of manufactured emotions may assist individuals in better understanding the impact that thoughts have on emotions and overall mental health. While I have known about the relationship between thoughts and emotions within the cognitive therapy, this terminology and explanation of manufactured emotions within the CPT model has provided me a new approach in presenting this complex idea. The second concept I have integrated into my personal counseling approach is that of stuck points. Stuck points are directly related to manufactured emotions and are defined as dysfunctional cognitions related to the traumatic experience. Within the CPT approach, the therapist will gently challenge these beliefs by using Socratic questioning and worksheets. The concept of stuck points could be an integral part of my counseling theory in many different realms. For example, cognitive distortions significantly impact a variety of psychological outcomes and pathologies. Therefore, stuck points would be extremely beneficial with a multitude of clientele. Moreover, the utilization of stuck points in Christian counseling could have enormous implications. The final way that I've been able to implement CPT concepts into my personal counseling approach is regarding the integration of Christian themes into CPT. I've already been able to implement faith-based concepts into my approach with Christian clients that were presented to me in spiritually informed CPT. The main way I have done that so far is by using the spiritually integrated challenging questions to assist the client in identifying spiritual distress and stuck points related to their current distress level. Thank you very much.